Hello, Dr. Dou.
Hi, Professor Gao.
Hello, Dr. Dou. Can you hear us?
Yeah, I can hear you.
Now
Hello.
you are online.
Okay, thank you, Professor Gao. And good morning, dear colleagues and friends. And it's a big honor for my team to do a live case on the morning of opening ceremony. And first, I would like to introduce my team. My right side is Dr. Yin Dong, and who is also the intravascular imaging interpreter today. And I also have my fellow Dr. Wang, a nurse, Ms. Peng, and technician Zhong Wei here. And first, Dr. Yin Dong will introduce the case to you.
Good morning. I would like to introduce the case overview. This patient is a 59-year-old gentleman. His risk factors included smoking, alcohol ingestion, hyperlipidemia, and hypertension. He has suffered effort angina for 6 months, but no previous MR and no previous CABG. Recently, he has received a DES in LAD. This time, he referred to our hospital for RCA staged PCR.
Okay, today we recheck the angiography. Would you please put the angiography on the screen? And today's angiography showed that patent LAD, no very good LAD stent, no stenosis. Next, from the caudal view, circumflex is good. Next one. At right coronary, we found a tight lesion at the distal right coronary and a moderate lesion at right coronary middle part. And then we checked the OCT today, and please put the OCT image on the screen, and Dr. Yin Dong will interpret that.
Yes, we have already performed the distal RCAP OCT. From distal to the proximal, we have the tighter lesion. The minimal lumen area is 2.3 millimeters square, and there's no significant calcium, just fibrous plaque. And we will identify the distal and the proximal landing zone. Here is the distal landing zone. The EL is about 4 millimeter, and the lumen is about 3.3 millimeter. And now is the proximal landing zone. The lumen is about 3.4 millimeter by 3.8 millimeter, and the vessel size is 4.15 millimeter. So my suggestion is 3.5 by 18 millimeter stent. Also, we do the angiographic coagulation. You can see this is the distal landing zone, and this is the proximal landing zone. We will put the stent by the coagulation guided. Also, we performed.
I'm sorry, I'm going to jump in. I don't understand why. First of all, you're focusing on the distal lesion rather than the proximal, because they're both intermediate lesions, and it's impossible to decide which of the two is hemodynamically significant. And it's entirely possible that if you did FFR on this case, it would not be below the ischemic threshold.
Definitely.
So it's the wrong test to decide whether or not to treat. A lumen area of 2.3 on OCT is rarely associated with ischemia, at least according to the 7 or 8 small studies that have been done. And I just don't understand. It's the wrong test to decide whether or not to treat this right coronary.
Actually, we calculate the QFR before today's procedure.
Yeah.
And the QFR distally is 0.78.
Yeah, I would
and today we also check the OCT for middle part RCA. Would you please show the middle part OCT?
I'm sorry, QFR is not ready for prime time.
Okay.
It's still an investigational technique.
I think the key thing in this case, and Kefe, it's good to see you in person, and congrats on that case yesterday. is I think one of the demonstrations was number one of the software, number two was the use of a novel first-in-man stent.
Yes.
And
yes.
so I think that upfront, let's accept the fact that the decision was made to revascularize the patient, and then show us
Yes.
how you're going to do it in terms of this device.
Yeah, thank you. And actually, the lesion is nothing special. This morning, a young guy told me lesion is too simple, I should left it for him. But the special thing today will happen is the stent we're gonna use. And the stent we use today is IBS. It's iron-based bio-resorbable scaffold. And would you please put the
By the way,
scaffold,
we also performed the middle to proximal as a
No, Dr. I will show them the introduction of the IBS. This is a very special scaffold. The backbone is based on iron with 0.05% nitrogen. And there's a zinc layer out of the iron to control the corrosion of iron. And also the outer layer of the stent is PLA plus cerulomers. And the total thickness, the thickness of the strut is only 70 micromillimeter. And the major advantage of this stent is about 1.5 years later, the complete corrosion will happen. And a small particle will be transferred to hemosiderin by macrophage and moving to the adventier of the artery. And then the lesion will be healed and the stent disappeared. So it's a new generation of bioresorbable stent.
And
Is
so
there any comment?
One second. I'm going to ask Patrick to make some comments on this. But so does any part of the stent remain, or is the entire thing gets corroded away, as you said, after 1.5 years?
After 1.5 years, after complete corrosion, only hemosiderin remained there. And by macrophage, it moved to the adventier, and nothing in the intima.
Okay. Patrick, what are your thoughts on this, and maybe others from the panel to comment too?
No, I think that in China there have been for a long time of research about the iron solution for biodegradable, and they went through a very difficult phase where you have the oxide of iron, which is not very good for the tissue. So you have seen there's multiple layer of encapsulation there, and the final result is to have something which should be neutral from the point of view of oxidation. I share a little bit the opinion of Gary. I mean, it's an intermediate lesion. The first one is long. If you look at the flow in the PD, it's also not a very brisk flow. So this is really a case where in some other place there were a combination of pressure and velocity to figure out exactly how much is the epicardial conductance and microvasculature in concordance, because you can fix the epicardial vessel and you will not fix the issue of angina pectoris. But the naked choice is obviously a case for demonstration of the iron bioresorbable, which is a great novelty and stimulate a lot of people. If we can fix that, I mean, you have all the advantage of the metal with the advantage of the bioresorption. That's the dream.
Yes, I totally agree with your comment. And now I would like to show you the out of the body, show you the stent. And can you put the camera and focus on this stent? 再近一点。
So they're zooming out. So if they can zoom in, no, that's good. Just focused.
Yeah.
What is the profile of this device came on the balloon?
The profile is not large, and I just introduced the thickness of the strut is only 70 micrometer blown up, and show this to the.
Yeah, that's also major advantage to have something, to have a strut thickness of 71 micron, if I heard well.
Blown down. down.
Yeah, the thickness is 70 microns.
70 micrometer.
Patrick, do we know anything about these in terms of, if you will, absorption and dismantling in terms of the necessity for apposition, like with the polymer scaffolds?
Yeah, I think that when you got to thin struts around 70 micron, the chance that they get embedded in the first place, and you can afford the radial force on that, so you capitalize on the first place on a good embedment. Then if there is nothing which is impeding the coverage by the tissue, then there is much more chance that the device will be encapsulated, that's the word we use, and then the chance that at the time of the dismantling, anything will protrude into the lumen is quite reduced. That's at least the theory.
Theory.
Unless there's side branches or otherwise, but that's overall minimal.
Yeah,
So that's
this-
what it looks like.
We have expanded the stent out of the body. You can see that, and I pinched it. I feel very strong resistance, and they also do some in vitro test the radial force and the pushability and other physical ability is very good. And also we can see I can make like this. The flexibility is good, and so I think. Today, I think it is the first time to implant this stent to a human in the coronary artery. Right, Professor Gao?
Yeah, this case is a really first in man case for this eye bio-resorbable stent. According to our animal data, this stent from 4 months, there are some point there'll be a fracture, but they will keep inside because they're very thick, and the endothelialization is very early. It's earlier than the sense. So usually, after start corrosion, there will be no strut to the lumen. So, or many animal data, but no thrombosis so far.
And the delivery kinetics of the drug is still somewhat delayed, correct? Because there's a polymer component in addition to the stent itself.
The drug released totally around 3 months, and the polymer degraded around 6 to 9 months, and the iron corroded around 1.5 years. But after corrosion, there's some hemosurgery will be transferred to the advanced tissue, and keeping advanced tissue sometime, then move to like spleen or lymph node. So far, from animal data, the biocompatibility is very good. It's very good.
That's great. I think we have to come up with another word than corrosion, though, because that sounds like rust.
It is rust.
It's rust. It's really rust.
Yeah, it's rust. Yes.
So we call corrosion. Then corrosion, the bioresorbable. They corrode it. Then the article become the hemosurgery.
Just now, I just finished the pre-dilatation using the 2.5 NC balloon, and I choose 3.5 by 不要大呼吸啊，不要深呼吸，均匀呼吸。3.5 by 18 millimeter IBS.
And as far as sizing goes, you can take this up about half a size or more than that. What are the characteristics of this compared to more conventional BRS platforms?
Okay, blown up. 2, 8, 9, 10. Oh, down. And give me a 3.75.
3.75的球浪打。
So Professor Gao, if you took this, let's say that vessel is actually bigger than 4, if you took it up to 4.25, 4.5, would it start having issues, or it can tolerate tolerances of that?
They can increase around 1 to 1.5.
Okay.
Yes, before I implant the stent, asked the engineer from the company. They said you can use it just like other regular mental stent.
So how, maybe some comments from you. Is this now the next wave that we should start approaching, where we maintain these radial force characteristics, but yet have metals? I mean, there's clearly some interest in this regard.
Yeah.
Well,
Maybe
definitely
first
you
go,
need some radial support, and the metal can give you the radial support. I think that it's the beginning of a second generation stance, but we'll have to see whether we do get some other long-term problems after the hemosiderin is going or not going away.
Yes, you are very right, Dr. Lawton. Really, the hemosiderin stay a long time, and they move very, 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 very slow.
16.
I mean, unfortunately, it's going to take several years to figure that out.
Yeah, I mean, we do not know what's the reaction of the hemosiderin in the plaque itself.
What happened?
It's a new constituent of the plaque, which deserves some long-term attention.
Pepe, we've lost you just briefly for a second, so we may continue discussing a little bit.
So I guess that these stents are radiopaque on multi-slice CT scan.
Would have to be.
Yeah.
Have to be, and the hemosiderin, do we know about it? Because the hemosiderin, as far as I remember, it is the final pathway is the reticulum endoplasm of the cell. That's where it goes, that's a place where they will be loading, but how long is that visible if it goes in the adventisia? Because that's what Dr. Gao told us. It goes in the adventisia for some times.
It'll be interesting to see if on CT whether the adventitia then becomes opaque. Although if it's very particulate, it may not, because the resolution may be an issue. But I think time is going to tell. This is unknown territory.
Right.
Yeah, we have some study use a micro CT. They use a micro CT, we cannot see the hemosiderin. But use OCT, we can see that. OCT, we can see some shadow.
Okay.
This is the hemosiderin is in adventitia or in the plaque?
In adventitia.
Okay, because as we see some of the deposit of the end of the skin, the hemosiderin will last for long years.
Long time.
Time will tell,
So I think we're all very curious to see this OCT run to see what its characteristics are.
Yeah, it'll look like a metallic stent, I assume, because it's a metallic stent.
Actually, the radial force is almost similar to sense, even a little bit stronger.
I mean, it looks like it has some self-expanding characteristics in the sense that when you flex it, it doesn't deform like a standard balloon expandable stent.
该定什么？位置没问题。好，准备好了吗，学生？你说可以就可以。
Okay, that's a nice run. Look.
I mean, it looks like a metal stent, but but there's like tissue coverage, or it's embedded into the plaque.
What's that?
Yeah, that's what I was mentioning. When you go in the 61 micron, these things get embedded in the vessel wall.
Right.
And that might be very positive in the future.
It's too fast.
Do you think that you have some damage that will cause more proliferation because you get some more optimal damage?
I mean, there's been a long debate how much struts of 60 micron get literally cut like in the butter, you know, the wire. But so far there is no evidence. I mean, the relationship between thickness and neointima is clear. It's more related to shear stress, but the specific damage of something penetrating in the vessel wall has not so much been investigated.
And that stuff is left over from the pathology studies, you know, the old work of Rob Schwartz and so on, which we never saw in humans, you know. But you can see how much plaque is, you know, has extruded, and it almost looks like there's these tiny dissections in the plaque that's inside the stent. But in terms of what it looks like metallic stent, it's well expanded. You just see a lot of, I mean, it's just well embedded into the tissue, which is something unlike we typically see.
Yeah, Gary, I have a question. Could you see the picture? Can we interpret, for example, if we do not know, we do not aware, we are just after the implanting, can we interpret this as anesthetized?
You can misinterpret it. See? Well, first of all, we don't use the term anesthetization with OCT because it's below the resolution. But you could look at this and think that there's neointima.
I mean, I think if you were to look at this image or some of these frames, it almost looks like, you know, a month after bare metal stent type of thing.
Yeah, exactly.
See, do we know how long does it take for the intima to grow? And based on that, how long should we advise antiplated because of the slow degradation?
Yeah, according to the pig model, 1 week we can see the under the 2 weeks, almost 60% covered, and 1 month almost totally covered in pig model. In pig model.
So how long would you suggest to have antiplatelets?
We still, in our first in-man study, we still propose one year, because maybe because in 1 year it's safe.
Dr. Gao, did you do some study on fistula? You know, the fistula, the type of work that Ron Waxman has done with the Magmaris, comparing the Absorb, the Magmaris, and the Orsiro, and obviously the magnesium has anti-thrombogenic properties that even the Orsiro and certainly not the Absorb do not have. Any type of fistula analysis in your stent metal?
Yeah, in animal work, we did some fistula model, and there are no thrombogenic compared with other stents.
One other comment about the tissue that's protruding. You stop right there. Just stop. You see from like 1 o'clock to 3 o'clock, where you have most of the tissue protruding, you also don't see the metallic struts. So that's probably lipid or necrotic core protruding into the in the stent. So that, you know, the embedding, at least at that point, is a little bit related to underlying plaque composition.
It's a region where you have very, very quickly attenuation, Gary.
Right, exactly. You know, so it's not fibrous. It's lipid. It may be necrotic cords. But most importantly, as you see, you don't see the struts. So if you just don't see the struts, that's, you know, even somebody who doesn't know a lot of imaging should say, you know, there's a reason that I don't see struts. And the only reason you don't see struts is if there's lipid.
So Professor Gao, can you tell us a little bit about the use of OCT in China? I mean, obviously this is the co-registration system and pretty state-of-the-art. How common is it, you know, in the audience, how many people would have these types of systems in their labs?
Yeah, OCT in routine clinical practice is not very common use. But right now, I think more and more cath lab use OCT, most of for some studies. But for clinical, I think for routine clinical practice, more and more cath lab use.
So, Kefe, were you going to say something?
Yeah, we have finished the OCT examination. Dr. Lindong, you can explain to the audience.
Here the stent, from distal, there's no significant edge dissection, and here there's a tissue protrusion, and here's the MLA site, but the stent area is about 8 millimeters square. So the proximal is well opposed, and there are no edge dissection at the proximal edge of stent. So I think there's no need to post dilation anymore. Thank you.
Yeah,
I think
I agree. And yeah, because a little bit tissue protrusion and the stent is well expanded, so I will stop to do anything for this lesion. Do you agree, Dr.?
Let me just support that. The risk of post-dilating at this point is you may get more tissue intrusion, and you'll embed the struts even more into the vessel wall. You think that if you post-dilate it, it may go away, and it may, but you have just as much risk of making it worse.
I think that's why that stent measurement that you took from the frames where you could actually see the struts allows you to determine that you have good expansion, at which point, further post-dilatation is not going to help.
And there's also data to suggest that this stuff resolves over time, that the lipid inside the stent tends to get organized, and if you look at it in 6 months, it'll be quantitatively less and qualitatively less lipidic.
So for the sake of argument, going back to the initial point that Gary made, if you were going to assess this case physiologically, would you use, David, would you use IFR, would you use FFR, would you use PDPA? What's the sort of state of the art on that right now?
Well, probably FFR. I mean, you've got 2 lesions. I'm interested to hear what they're going to do with the proximal one there. But I mean, in order to be able to assess both, I think that's the best technology.
Patrick, any thoughts or time?
Yeah, it's of course that in first place you want to do a pullback. I mean, and have a good co-registration to say what's coming from the distal lesion and the proximal lesion. The second point, if you are more sophisticated, you will start to do pressure velocity loop distally to see if there is issue with microcirculation. It's a catheter which is a little bit more cumbersome than in the past, a single pressure and a single wire. But these people provide good information on decomposing literally what is epicardial conductance and microvasculature.
After having such a good results in the distal one, should we stent the proximal one if you have such a big lipid core?
Well, I mean, in terms, let's just talk about hemodynamics. It's entirely possible that the proximal lesion will now become hemodynamically significant because you've relieved any contribution of the distal lesion. I mean, that's just the reality of the interaction with tandem lesions. It's relatively hard to predict, and something that before wasn't a problem now could be a problem because you've relieved the secondary obstruction. And the only way to tell is to check it. And of course, we're all biased by the fact that angiographically, now the rest of it looks great, and this other lesion doesn't look so good. So,
I mean, one of the reasons I brought it up actually is because just today, or early release in JAMA Cardiology, there's a review both on the use of various techniques plus an editorial on it as well, because this serial stenosis issue comes up all the time. And Patrick's point about the microvasculature is also well taken, because even if you sort out what's going on epicardially, that might not treat the patient in the end. So, Kef, are you going to show us the fly-through now?
For the distal part, the distal RCA lesion, I think we all agree with the results, and we stop the procedure here. But for the middle RCA lesion, I totally agree what you just mentioned just now. And I think we will check FFR or QFR or off camera and decide whether to treat it or not. But based on our previous experience, and the OCT showed the MRA is more than 3.5, and usually we check FFR always more than 0.8. So in most of the case, we will not stent middle part RCA.
And this is the one indication I think where IFR is clearly better than FFR, because it sorts out tandem lesions much better than FFR does without having to do it in a stepwise fashion.
Yeah, and especially because this lesion is not short and there's some length to it, that MLA characteristic, especially in a big vessel like this, can sometimes be misleading. But I agree with what you're going to do, and thanks so much for the demonstration. It was really a nice way to discuss the technology. Ron, maybe you want to comment briefly on this technology versus other metallic bioabsorbable platforms?
Yeah, thank you. This is really a big deal. I mean, it's probably more than 10 years of work on this iron metallic stent, which had many iterations, and I have to congratulate the whole team and Professor Gao that was leading this project. With respect to the nomenclature of the technology, I think we have to differentiate between BRS, which is more applicable for a general term for all the bioresorbable, to MRS, which is a metallic resorbable scaffold. So we have now two. We have magnesium and we have iron, and maybe this would resurrect some of that field of bioresorbable that seems to be almost forgotten or been left without any clinical utility. This may be a change when you're getting to 70 to 90 to 100 micron with metallic stents. And I have to say, I reviewed all the animal data. It's been made many iterations, but it is a big deal to see it in China for first time live case. So I would like to congratulate Dr. Gao and Lifetech and all the team that worked on that.
Okay, thank you, Dr. Waxman.
I agree.
Okay, thank you, Kefei.
Okay.
Thank you, Kefei, for your
Thank you
wonderful
all.
live demonstration. The very first time. Thank you.